I just got a notice. Did you do
It
it?
is trying to get on.
I did.
Okay. You want to give him a minute?
Yeah, he's
Oh.
trying to get on the call.
Yeah, we just got a message from Dr. Jensen that he is joining. He's having a little bit of issues connecting. We will give him a second. And
I should answer him.
then we'll get started. Thank you, everybody. Alrighty, good afternoon, Dr. Jensen. We were waiting for you. Appreciate you joining and morning.
Okay,
Floor is yours to get this started.
good afternoon, everybody. Can we call to order and do our roll call, please?
I'd be happy to. To start off, Dr. Sandra Horning,
Present?
thank you. Michael Bolu,
Present.
thank you. David Slattery. Dr. Lloyd Jensen,
Here, present.
thank you. Bobby Sullivan,
Present.
thank you. John Middleman,
Present.
thank you. Jeremy Sonnenschein, Irene Navis,
Present.
thank you. Cara Smith, Zeb Namora,
Present.
thank you. Nicole Brown, Kevin Haywood. These are our ex officio members.
He's
Uh,
excused.
Thank you. Tiffany Collins, Jennifer Badinsky, Christine Forsberg,
Present.
thank you. Jenna Sir, Andrea S,
Present. I know
thank
she was,
you.
Jenna was on.
Tabitha
Yeah.
Hart,
Maybe
Present.
it didn't go through.
thank you. And Jamie Carlson,
Present.
thank you.
Rachel, Jenna is on there.
I do see that. Thank you so much.
Thank you.
We got you.
And we do have chair or quorum chair. Sorry.
All right. So Michael, I'm going to ask you to read the public comment.
Yeah, no worries. It is a mouthful. Michael Bolu for the record. Agenda item 2 is public comment. Public comments may be presented in person, by computer, phone, or written comment. Due to time considerations, each individual offering public comment will be limited to not more than 5 minutes. If a person would like to make a public comment by calling in, dial 1-775-321-6111 and enter the following conference ID code when prompted, 155-326-762#. A person may also have comments added to the minutes of the meeting by submitting them in writing either in addition to testifying or in lieu of testifying. Written comments may be submitted electronically before, during, or after the meeting by emailing Michael Bololu at mbololu@health.nv.gov. You may also mail written documents to the Division of Public and Behavioral Health Emergency Medical Services Program at 4150 Technology Way, 3rd floor, Carson City, Nevada, 89706. Do we have any public comment at this time? Bring it up before.
Okay. All right. Review and approval of the minutes.
Michael Bolu for the record. I'm sure some committee members did notice that minutes were not provided to this committee. I do apologize. With the state cyber attack, the video recording, transcript, and everything that we were working on was isolated and unavailable to us until approximately a week and a half ago. By the time we got access and figured the minutes needed to be done, we simply did not have time, so I apologize. I would like to propose a motion to table this agenda item until next meeting, and we'll review both the August and November minutes together at our next meeting.
Can we have a second on the motion?
I second.
All in favor?
Aye.
Yeah.
And I'm sorry, just for record keeping purposes, who seconded
Tabitha.
the Tabitha? Thank you, Tabitha.
All in favor?
Aye.
Aye.
Aye. Anyone opposed? Okay, the motion carries. All right, we're going to discuss some of our projects. First is hand-heavy implementation.
Michael Bolu for the record. So I do have a update for the implementation of Northern Nevada. We did run into an issue with the grant, the ASPR grant that was helping fund the rollout to the 7 identified agencies within rural and Northern Nevada. We are hopeful that we can start that contract and grant process by the end of the year, but I will have to reach out to the other program that we are working in coordination with to get an update on that funding. Unfortunately, this program cannot fund that entire project by ourselves. I was hoping Nicole Brown would be here to provide an update about the hand-heavy implementation down here in Las Vegas. I did speak to the EMS coordinator for Las Vegas Fire Rescue. He did say that it was actually going very well. So hopefully we can provide further update of the progress that we have for the Clark County Fire Departments at our next meeting. Does anybody have any questions for item A? Hearing none.
All right. Safe Transfer for Children Initiative.
So this is kind of the big one today, right?
Yes, it is.
So I know it wasn't really well known to the committee members, but today we had a large distribution and pickup event for the AEGIS wraps that we purchased some time ago. We ended up purchasing a total of 450 units. We distributed 213 of those to 5 participating agencies within Clark County. It was Las Vegas Fire Rescue, Clark County Fire, Guardian Elite Medical Services, AMR, and Medic West. They were all present today at the Southern Nevada Health District, and I would like to thank Southern Nevada Health District for sponsoring this event and loaning us their conference room. We provided live demos of the equipment, and then we had 2 news channels come and take personal interviews of myself and Dr. Jensen, as well as video recordings of a demo call that involved an AMR ambulance and Guardian Elite Medical Services crew. So I'd like to thank everybody involved. I believe it went great. We had a good time. It was pretty stressful, but it was also pretty fun to have the media there and get some broadcasts out. So we're hoping that this positive news attention will, one, continue to support and promote this program in our committee, but as well as get the agencies who did not respond to my initial emails on board. Hopefully it'll be less of a fight to get people to want to participate in such initiatives. So we're rocking and rolling. The other 5 that we distributed are for training centers within Clark County. We gave 1 to Pima today. They sent a couple representatives and we borrowed 1 of their mannequins. Nicole, I just saw you go on. Southern Nevada Health District has your AEGIS wrap for your training program at Mountain View. And we have the College of Southern Nevada. They'll be getting 1. And then I let Southern Nevada bring up, make the official determination of who else within Clark County who provides education would get the extra 2, or if they wanted to keep it as a resource to loan out for agencies, et cetera. So today was a great day. It was very productive. I think it went really well, and hopefully this is one of many initiatives that we get the ball rolling. With the other 232 units that we have to distribute, we do have plans to distribute products in Nye County and Esmeralda County on our travels back up to Carson City tomorrow, with further plans to distribute in Northern Nevada by the end of the year. Lloyd, I see you have your hand up.
Hey, thank you very much. I just wanted to say thanks to everyone who made that effort to be able to do that, and the organization that you had. It was very, very helpful. And really appreciate that. The 2 things that I think we want to try to address is, the state statutes, as I understand them, still would say for the transfer of a newborn, or let me rephrase this, transfer of a patient, that there's only 1 patient per unit per ambulance. And so somehow we have to try to set up something that allows this to be under the state statutes still. Is that correct, Mike?
To my knowledge, and what's been happening, whether it's statute or not, is if there's an infield delivery or a mom who's recently delivered a child calls an ambulance, they are transferred together. That's what I see in the EPCR reporting system. I will have to review those regulations and administrative codes. Now, is that potentially a policy in Southern Nevada Health District's protocols as well, or their policies or procedures?
Not that I know of. I have a copy of them and I have to look at it, but I don't remember that being in there.
Yeah.
So
we'll double check, Dr. Jensen, but at least with the EPCR reports that I see for infield deliveries, there's not been duplicates, which would indicate to me that 1 incident, 1 report is 1 transfer using 1 crew. So that's certainly a good topic to bring up, and we can look into that.
Because that might be one of the things also to kind of, get that set, whether we take that before, whatever agency that would need to adjust that. But it's also, it might be a good way to highlight it, that, hey, this is, an acceptable way, especially of saying this would be the only acceptable way because it has been crash tested. Otherwise, as the patients are bringing them in, or the EMS are bringing mom and baby in, if there were a incident of mom becoming less responsive and dropping the baby or other things like that, where we have made this effort to try to alleviate that, somehow getting that to be on people's radar would be helpful.
Absolutely.
there's the other hand.
And Nicole, we see your hands up as well.
Yeah, I think you're going to be fighting an uphill battle on that one because it is very specific for transportation, that children are to be in a approved safety device. So I think that in order to do that, we would have to change statutes.
This is approved.
This is an approved device.
But it's not like legislative though. So
Exactly.
agency
I think
wise, Yeah, so agency wise, they can't force people to use them yet. So I think that should be the next thing that is probably on the list to go after, because it is an amazing device that can be so helpful.
Well said, Nicole. I think that's helpful. But I mean, I think as Michael had said, that it seems to just be implied that, hey, this is an appropriate way. But I think, as Nicole is saying, that as I understand that we'd want to have the wording change such that this would be considered an approved device. And since it's one that has had, some crash testing, it is a safe transport system. So somehow we need to look at that and have somebody, kind of help us figure that out.
No, I agree. And these are all valid points. I would say if we can get together, I can work on our NRS and NAC 450B. Nicole or Dr. Jensen, if you have any language specific to Southern Nevada and their protocols or regulations, because I do know we deviate, the entire state follows NRS. Our office is guided by NACs. Southern Nevada has their own policy and procedure manual. So we can get some language together. Maybe we can come together as a committee, review that information and language, and come up with a proposed change or update. If you guys are willing to help me with the Southern Nevada language.
Yeah, I can definitely work on that here in the next few days. And I'll reach out to some agencies and see what their insurance captives are allowing so that we can make it so that we only have to do it once and can get everybody involved.
Well, good job. Keep me in the loop as well.
Thank you, guys. I appreciate it.
Nicole, could you comment on the hand-heavy implementation since you're on the phone?
I would love to, except for I don't really have a lot of updates. City has been getting ready to gear up. They've had some leadership changes, so that's kind of paused where they're at. Their EMS division has changed from EMS to training, so there's some changes that are happening there. But we're seeing a lot more use out of hand heavy through county. We're talking back now with community about possibly them getting involved. Henderson would like to sit down at the table again and have the conversation. So just in everybody hearing about it, we're starting to get some more movement there as well.
Great. As long as the ball's moving forward.
Yeah,
Nothing's ever easy.
it's definitely moving forward. I think that Dr. Morgan had higher hopes of it being fully rolled out by the end of the year. But with all of the leadership changes, with Chief Perillo retiring and new leadership coming in, it's just kind of been paused.
Understandable.
All right. Pediatric pre-hospital education resources to include development of a pediatric research panel. I had a question about the MCI tabletop exercise, because I know that our pediatric emergency medicine fellows wanted to do that.
Yeah.
If anybody has an update, are we able to let them do that, or who do they contact?
So who was managing the tabletop? Because I know it wasn't me. Was it PHP? Typically, public health preparedness and their emergency management teams do those MCI
It might have
tabletop
been.
exercises. And I do know Southern Nevada and Southern Nevada Healthcare Coalition sometimes runs those. They would be more invited if we were sponsoring one. We have discussed doing MCI trainings with the Disaster in Seconds kit that PHP owns and was willing to loan out to people. But I would reach out to the sponsor of that tabletop exercise, because I know it's unfortunately not something our office typically does just because of our staffing.
But last meeting, somebody talked about that and how it was free, and they would help set it up, and
Those minutes would be helpful.
Yeah.
If they weren't locked away on a server.
yeah,
Um,
This is Andrea. I'm pretty positive they're referring to the disasters in seconds because it can be used as a tabletop or a functional exercise. And state PHP did say that they could help set it up, and it comes with a variety of different scenarios. Um, I, I'm like 99% positive that's what we're referring to.
Right.
and that's what I thought, but I trust your memory better than mine at this point, so.
So if we could get a contact number for them for the
Yeah.
fellowship, that would be.
Yeah, I can give it to you right after this meeting. It's
Okay.
Vanessa Mason at PHP.
Okay.
I'll give you her office phone and email. You can
Okay.
reach out. Because it's a great tool and I've been trying to get people to utilize it. It's free. I mean,
Right,
they would just need to figure out how to get it down to Vegas, but they have an office down here as well. So
right. Okay. Perfect. And we have some hands up.
Andrea, just the person who's developed that, Scott DeBoer, he's actually going to be here in Las Vegas this next Tuesday for our transport team. We do a training session with him every year. And so if you just had one of your fellows contact me, we could kind of make contact with him. He would just love to know. And if nothing else, it's just, making that contact. Because he's developed kind of emergencies in seconds. There's the disaster in seconds that he did with EMS World when they were here last year. And it's just a very, very well done program, and it can be adapted to almost anything for the mass casualty training and other things like that. So just have them reach out to me. That would be in addition to what you were describing, but if they're interested, we could make that contact.
Great.
Thank you.
Right. Another hand is up. It is.
Nicole, is your hand still up or did you hit it again?
No, I hit it again.
Okay, go ahead.
Just in the MCI world, we are starting our planning for our big MCI for next year. So if those pediatric fellows, we do have pediatric patients that we build into our scenarios. If they want to participate in our big drill, we'd be more than happy to have them out.
Jenna, are you still on?
Yeah, that'd be really cool. When do you do it?
We do it April, hold on. Let me not misspeak and grab a calendar real quick. It'll be Wednesday, April 1st.
Okay.
We have pre-planned about 120 patients and about 45 of those are going to be pediatric.
Okay.
And it's a live patient simulation drill. So
Yeah.
they'll be
Okay.
active.
Let me see if we can arrange some stuff to be there.
Okay.
Thank you.
And Nicole, I mean, I don't know what my schedule is next week, but if you have a reason for me to come down and help you guys in any way, let me know.
Absolutely.
I'd offer myself as, whatever you would need me as, I'd be happy to come down if I'm available, just to throw it out there as well.
Yeah, once we put it, we have our first pre-planning meeting for it next week. So as soon as I get the details, I will send it out to the group. Well, I'll send it to you and then you can send it to the group. And anybody that would like to participate, you're more than welcome to join. We do a multi-agency large-scale drill here in Las Vegas. We're the only agency that brings everybody together. So we have participation from county, city, Henderson, Boulder City, Mesquite, Moapa, and then all of the private agencies, community, AMR Medic West, GEMS. I feel like I left somebody out. North Las Vegas Fire. We have 66 students that will go through the drill along with the residents from Mountain View's residency program. So about 25. So we start our drill from 911 incident to discharge at the hospital. So it's really all encompassing.
Sounds great.
It is great. Anybody else? We have a couple of hands still up.
Andrea?
Yeah, it may be helpful to share with this group the contacts for all the healthcare coalitions across the state. They're all required to do exercise with pediatrics. So just like the South, Washoe County also does full-scale MCIs that also involve pediatrics and, from field to discharge that incorporates all healthcare. So that could just be good knowledge for everyone on here of coalitions who are organizing or play an active role in the organization of those exercises. So regardless of, it'd be NHA for most of the rural community, and Quad County preparedness for some of the counties up here in the north. So
Awesome.
Thank you.
Who else?
Dr. Jensen, is your hand raised again?
Oh, I just hit it twice.
Oh, no worries, no worries. Does anybody else have any comment about item C or discussion?
All right, pediatric disaster preparedness. Irene.
Hello, everybody. Irene Navis with the Western Regional Alliance for Pediatric Emergency Management. Thank you, as always, for inviting me to speak on RAPM activities. We have a number of new work products that, Michael, I will share with you via email. If you choose to, you can put them on your website as well. There's a number of recent just-in-time videos for pre-hospital and hospital clinical support. We have a number of documents that are new that I'd love to send you. But we, in RAPM, we work primarily in pediatric emergency preparedness, but also address family and caregiver issues as well. We have regional resources, pediatric surge, resources for providers, legal and policy guidance, resources for families, mental health resources, crisis standards of care, and infectious disease. And I just want to give you a couple of examples of resources that we put out in a sort of a just-in-time fashion. We have a second. Oh, it's under news in the RAPM website, and I'll know you've shared that before, Michael, but you may want to share it again when you put the notes out, the minutes out for this meeting. During the summer, we put out a series called Keeping Kids Safe, and this was information that we put on our website that is sort of a summary of the issue and then a bunch of resources that folks can refer to. We had one on extreme heat, pavement burns, and chemical burns. We had another one related to exposure to tear gas, and that one was for parents and one was for hospital personnel, pre-hospital personnel. And especially during the protests that we had this summer and in recent months, we had a tear gas one, and then one more general related to keeping kids safe during protests and civil disturbances. I think I mentioned previously that we had a series on wildfire, chemical exposure, and debris flow. And what we do is whenever there's a real world event that has to do with information that we've put out in the past, we put it back out. It's always on our website, but we put it back out during social media. So if you're following RAPM on social media, both Instagram and Facebook, we also have a Twitter page. Those pieces of information are readily available there as well. And we have, as always, our training information is kept up to date. Just a few examples of just-in-time training video series that we've done. The most recent one is one on acute gastroenteritis. We have one on pediatric high flow nasal cannula protocols that with the respiratory season coming upon us, it might be useful. We have another one on pediatric rapid sequence intubation and another one on pediatric septic shock. Those are the most recent ones that we've completed. And so if those are of interest, those are available under just-in-time training on the website. We also provide a lot of resources through our coordinators. I have counterparts in the other Western states that are part of RAPM. And what we do oftentimes is participate in state level or local level or regional exercises in different roles. So we can be part of the planning team. We can help facilitate the exercise. We can be evaluators for the exercise. We also have a number of toolkits for exercise support. We have toolkit for MCI, we have toolkit for CBURN, and a number of others. I also have a bunch of exercise scenarios that I prepared for a training opportunity that I'm willing to share in case you need ideas for, especially for tabletop exercise where you have a scenario and then several discussion questions attached to them. Happy to share that. And the reason I'm bringing up all of these resources is I know with budget cuts in different programs, and we are also affected as an ASPR program, it might be good to be able to leverage our resources and work together. So if you have a gap in planning, training, and exercise that RAPM could perhaps help you fill in terms of pediatric disaster preparedness, we're happy to work with you to be able to fill that gap. So please feel free to call on me if there's anything that I can do to support you in any of those activities. Chances are we have a template or an exercise kit or some other bit of information that may help supplement and shortcut some of the work that you have to perform. I also wanted to mention that we recently completed and had published in a professional journal a companion piece to one, a article that I mentioned previously on radiological nuclear response, antidotes, and countermeasures. That was for pediatrics, and the adult version was recently published, and now we are working on chemical response for both pediatric and adult, and then we're going to finish up our series with biohazard response. And so just wanted to make you aware of that series. Michael, I'll share with you the latest published document. I shared the pediatric one with you previously, but if there's anything at all that I can do to support you or your agency as you do preparedness activities on a shoestring budget, please reach out to me, and I'm happy to answer any questions that you may have. Thank you.
Thank you, Irene. Any questions?
Irene, I don't have a question, but absolutely any resource that you're willing to share with me, I'll be happy to post to our website, distribute through this committee. The only thing about our website is we have kind of gone through a weird rebranding since the cyber attack. It was already planned, but our URL address has changed slightly. I will send everybody after this meeting our state EMS website and also the channel for the Nevada EMSC program. If you search Nevada EMSC program, it should come up in a Google search, but you're going to have the old website URL that's going to say 404 server not found, and then another URL just below it that says it's available. So I'll make sure everybody has the correct link so we can all bookmark it. We are working right now to get all those old links that don't work removed from Google searches. Safari, Firefox, IT is working on that, but that's a little out of my realm of expertise of how to get those away. They're no longer valid. Get them out of there because it's just leading to some confusions. But happy to post anything you're willing to share. Yeah, no, thank you for the update, Irene.
Sure. I'll also share resources that are relevant to this group from the Pediatric Pandemic Network. I'm the CBURN domain manager for that group as well. And so I have access to a huge resource library, and I will send you the latest in information and resources from there as well. Thank you so much.
Thank you, Irene. Next is EMS newsletter. That is me. I'm halfway through. It was a little, with the going down of the state system and now the federal system. It's been hard to put this together, but I promise that it will be done by the end of the month. So, because now, well, half of it's back up.
Yeah.
Yeah. Okay, updates from committee members relating to EMSC activities. Any updates?
Go ahead, Andrea.
Hi, I'm Andrea S. for the record, Preparedness EMS Program Manager for Northern Nevada Public Health. And I wanted to provide an update on the work, state PHP's pediatric work group for their state plan. This work group focuses on addressing pediatric capabilities in MCI events, but generally just for preparedness. We have recently finalized our objectives for this year, and I wanted to share some of those with you, just conceptually what we're working on. So taking a more proactive approach to engage specialty care within the healthcare coalitions, specifically focusing on pediatrics. Not all of the coalitions across the state have pediatric representation. This will be talked about later on in the agenda, but we will be reviewing the PEDS readiness reports and develop objectives to continue to work on as it relates to preparedness. We have been actively working on identifying legislative barriers or obstacles. Our last meeting, we had a presentation on the climate, or what does pediatrics in general look like across the state of Nevada, not just as it relates to preparedness, so we can better understand who that demographic is, and then discuss different legislative opportunities and who to better partner with to overcome barriers. And so that will continue to be something we work on. We're also promoting and working on just-in-time training for pediatrics, specifically in our hospitals. We're also promoting that disasters in seconds. Usually that kit gets checked out through the healthcare coalitions at the local level. And then, as I mentioned earlier, the healthcare coalitions are supposed to exercise, part of that being pediatrics. This year, they are expected to exercise one of their specialty plans. So this could be an MCI, chemical, a burn, infectious disease, but it has to have a pediatric scenario. And so I just kind of let you know that that is some of the work that work group is doing under public health preparedness.
Thank you. I'm
Awesome.
looking forward to our next meeting.
Under updates, I just want to bring up the crisis that we're having, particularly in Clark County, with e-scooters and e-bikes.
Yeah.
And what if we see that there is a role for us through our committee to do anything to support education about this, or what people think, because it truly is a crisis right now. We've had multiple fatalities, multiple injuries.
They go fast.
Yeah.
And a lot of the times
Right.
there's no protective equipment being worn at the time, and they're very quiet.
Yeah.
So
So it's something to keep in mind as we move forward, because it's really become a public health issue.
yeah.
So. 2026 Emergency Department National Pediatric Readiness Project Survey Update.
Yes, Michael Bullock for the record, and this is the time that I ask all of our physicians who have contacts at the hospitals to assist me. The EMS one is relatively easy. Most agencies and agency directors know me by first name, so getting that information from people and making them take a survey is quite challenging to get them to do it, but they inevitably give in to me. In 2026, and I believe this launches in March, we're doing the National Emergency Department Readiness Program. This is similar to the EMS readiness survey that we completed in 2024. We did achieve 100% response rate. We are one of 6 states and or territories to get 100% response rate across the nation. I was very fortunate enough to get a call from the University of Utah commemorating our effort of that response rate, and they even reached out to the governor's office, and I received a lovely letter from the governor and commending myself, but our committee as a whole and our program of achieving that result. Now it is time to do the hospital side. This is the survey I struggle with most because I do not have any contacts. We are looking at revamping our list. I will be sending out they are unlocking the contact license management systems contact list that the University of Utah has on file that was last utilized, I believe, in 2021. I know at least in Northern Nevada, there's been a lot of emergency departments that have opened since that survey. So we're going to need to review what's in our areas, what needs to be added, get those contacts added in, and then get those people to answer the survey. Our goal, as always, is to get that 100% response rate. It has proven difficult for our program to achieve that. I believe last time we had another EMSC program manager involved, but I don't want to place any blame on anybody because I did it pre-COVID and it was extremely difficult to get anybody to respond. But I want to say we're at a 66% was our response rate last time we did this, which was on the lower end of state hospitals. So if we can get another 100% response rate on the hospitals, that would effectively boost Nevada's reputation of these projects and initiatives forward. So as I get that contact list, I'll send them out to the committee. We can work together to finalize that well before the launch date of the survey. I've opted with the University of Utah to do an entire state-led program. In the past, we've had the University of Utah send out survey reminders. Nobody has responded to them. And when we get involved, action happens. So I figured, hey, instead of wasting 2.5 months getting no results, let's just start immediately and start tackling this. So just wanted to put that on everybody's radar. That contact list will be distributed as soon as I have access to it. If it's not already available, I have not checked in about the last week and a half, so it may be available. If it is, I'll send it out to everybody. And I would really appreciate, help. I will send a weekly non-respondent list to the committee. And if, Dr. Horning or Dr. Jensen, Renown hasn't answered, but we know somebody up there because the community is small. We can make that happen. So just wanted to put it on everybody's radar. And Andrea, I see you have your hand up.
Again, the healthcare coalitions have really close connections with those hospitals and ERs. And they typically, we found when state, doesn't matter where what stage, pushes stuff out, they don't really respond. But if we push it out or ask them to do something, they will. I was texting with ER director this morning. So you probably can get your healthcare coalitions to push it out, and you can probably get them to facilitate to get that answer, that information collected for you.
That is a fantastic idea.
And if you don't have contacts for all those coalitions, I can provide them to you, or state PHP should be able to.
Yeah, I'll if I can't get it relatively quickly with PHP, I'll reach out to Andrea. And I do know the contact for the Southern Nevada Health District Coalition because they asked for our state gap reports. And I told them, I'm sorry, I'm presenting it for the first time at our EMSC meeting. You're gonna have to wait till after Wednesday. So I'll send it to him as soon as I get back to my hotel. But I do have a point of contact there. But yeah, I think that's a good idea. That is what we've lacked in the past, is leveraging the resources, not only on this committee, but outside of this committee to accomplish some of our projects and initiatives. So I think that's a great idea to lean on people who have those contacts and that information. If somebody on a name-to-name basis, it's a lot easier to get them done than sending them an email and them going, I'm not interested. So.
Well, we'll fix this when we get our hospital recognition program up and going.
Yes.
You're mandated to do it to
Yep.
get certified.
Yep.
Perfect. Okay, review of the 2024 EMS National Pre-Hospital Pediatric Readiness Project State Summary.
Yeah, it's Michael Bolu again. Well, geez, I want to say this survey ended on June 30th at midnight in 2024. And about 10 days ago, that state report was finally released. It took a lot of issues. There was some iterations. It was going to get released in April, and there were some iterations internally, and then it went over to the feds, and they had some adjustments that they needed to make. So this report is finally available to us. I did send out attachments. Andrea caught it. I sent the ILS twice, even though it was labeled ALS, ILS. So I have the ALS on my screen. I also sent everybody an email at 12:42 this afternoon with those attachments. If you don't get it, reach out to me. I'd be happy to resend it to you. Now, this is public information. I do plan on posting this to the Nevada EMSC website when I get back into my office. But basically, this is our state gap report. For ALS agencies, it encompasses all 37 agencies that responded. That's all 37 agencies that we have in our state. So the way the scores are redacted, and if we all remember middle school math, which is almost harder than the older stuff because it's been so long ago, they broke it down into two scores. You have your average score, your median score. The reason why they went with a median and an average is average obviously shows us, whatever the scores are divided by the 37 gives us our average. But because outliers who either a couple agencies do really poorly or a couple agencies do really well, they don't want that to adjust. So they also provide the median. So we can safely say that the state of Nevada is anywhere between a 79 and 76 on a score of 0 to 100 for pediatrics. So we're a solid C to C plus. As we go down the report, it shows which agencies. Ooh, I scrolled down too far. My apologies. Which agencies on average scored. So it looks like we're doing really good with equipment and supplies. Part of our program is providing those supplies, especially to the rural agencies. In 2018, we purchased all of those pediatric emergency PD bags, like a first out bag, but specifically for pediatrics. Protocols, policies, and procedures. It's pretty good, but you can see where we start falling off the cliff is the last four is having a patient and family centered care in EMS. We're at about a 67% with that. That's better than most states, if I'm being honest with you. We're above the national average, but it's not great, and it's certainly an area that this as a committee, while we develop our EMS pediatric readiness program, need to focus on. Interaction of systems of care, quality improvement and performance improvement initiatives within these agencies are huge. And what we're seeing is the biggest issue right now with scores, averages, and pediatric care in general is the coordination of a pediatric emergency care coordinator or a PEC. That is a requirement for our ED readiness project. It will also be a requirement for our EMS readiness project that we're rolling out. But nationwide on all the calls is having a PEC improves everything above it. If an agency does not have somebody who's in charge of advocating for pediatric training, pediatric supplies, pediatric family care initiatives, especially with the hospitals and doing, interfacility transfer agreements specifically for pediatrics and what additional line items that you may need to consider when dealing with the pediatric, because you're not just dealing with the kid. When you're dealing with the kid, you're dealing with the family too. It's not great for a kid in Winnemucca to get flown by himself to University of Utah. Where are the parents? How do the parents get there? We need to kind of focus on you're caring for the patient, but we also need to consider the family. And that's a huge part of that PEC position. So, and as we go down, they were ranked the top 5 reported duties that their PECs do. So 38 agencies at the ALS level have a PEC. They oversee pediatric projects and QI initiatives. They promote pediatric continuing education. They ensure providers follow pediatric guidelines or protocols, ensure the availability of pediatric medications, equipment, and supplies, ensure pediatric perspective is included in development of those EMS protocols. If we're not thinking about the kids when we're doing the protocols are not going to work for the kids. So we can see here, I don't like PDF right now. So the agencies that had a PEC, average score, or I'm sorry, median adjusted score is 93. The adjusted score without a PEC is 92. That's quite a big difference in perspective of simple scoring, having one person advocating for this. So that's going to be a huge component of both, like I said, the ED and EMS readiness projects that we're rolling out. Hopefully we get that ED readiness project. I know it's on an agenda item, so won't duplicate updates. So skills check on pediatric equipment. Our state requires an annual skills that includes both adult and pediatrics for a reason. Demonstration at a skills station, we're doing great at 92%. Demonstration within a simulated patient, 95%, but only 49% have a supervisor observing pediatric care during patient encounters. And now I totally understand that is a very big ask for these agencies to say, hey, we have a pediatric cardiac arrest down the street. Instead of sending an ambulance and a fire engine, why don't we also send a supervisor or a PEC that sole role is to advocate for this? That's not only for QI, QA initiatives, but also have extra hands on deck. But at the debriefing, you have a supervisor that maybe wasn't in the call saying, hey, you guys did great, but I did notice these 3 things maybe we can improve on. Let's train on it. Let's practice on it for the next time. That is not happening, and that brings down the score of pediatric skills evaluation quite a bit. In disaster planning, 70% use a triage tool for pediatrics. 62% use antidotes for pediatric patients. Tracking of children separated from patients is only 57%.
Hurricane Katrina.
Yeah, I mean, and obviously these are disasters in which we have little to no control over. But I mean, as a parent's perspective, that is scary that you have effectively a 50-50 chance that you're going to get separated from your child and there's no tracking of where they are and what's happening to them. Also, family reunification and mass transport of pediatric patients. Those are the 3 areas that we need to improve on as far as disaster planning. So these were the top 3 proponents that Nevada agencies at the ALS level designed. These are their scores. If you have any questions about the data or information, feel free to reach out to me. I'd be happy to have a one-on-one conversation. We could really go in depth and we can bounce ideas, questions off each other. But this is the data that I'm going to be utilizing with this committee to determine what they need to meet as far as scores percentages to meet our 4 pediatric EMS readiness levels once we get that, established and approved by HRSA, et cetera. So ILS. So, and just to remind you, 79 median, 76 average. So safe to say we're somewhere in between or within those ranges. ILS, 12 ILS agencies in the state of Nevada. There's a severe drop off in scores for these agencies. I will say right now, I pretty much know why. The rural and mostly volunteers. Hopefully work with the Rural Transformation Initiative helps revamp rural healthcare in a way that includes EMS and ups these points. But there's a huge drop off if you have a medic and a paid service who is working on it to a part-time volunteer who's juggling life at home and maybe 1 or even 2 full-time jobs to afford the cost of living and then run on an ambulance. So once again, though, we're still very high on equipment and supplies, but pretty much as you go down the list, it gets worse. Only 39% had a coordination of PEC, which is actually pretty similar to the ALS agency, I think the big one for the ILS is there's practically no QI, QA, performance improvement initiatives within those departments. It's effectively, we did the call, we're doing the EPCR report, we're going home, and you can't blame them. They're volunteers. So when we're working on the levels for the lower levels of our pediatric readiness system for ILS agencies, how can we assist them potentially in improving these bottom 4 to 5 systems? Now, I do think patient and medication safety is going to be hugely affected as the years go down the line and hand-heavy or a similar medication dosage system is rolled out. So ILS is, they're going to have their struggles. From 38%, we dropped to 17% have a PEC, regardless of your level on our pediatric readiness project. A lot of it's going to have to do with training, education, equipment, et cetera, resources that not everybody has. Everybody will have to be a PEC to even qualify for the lowest level.
Yep.
So this will be a huge, huge change. And all 12 agencies reported the exact same 5 top roles of what their PECs do if they had one. So it's pretty interesting that all the ILS agencies, even though they had less PECs, were all on the same page effectively about what the PECs roles would be or are. Scrolling down, so with an ILS agency that has a PEC, their median adjusted score is 71, which is a significant increase from 57, right? And without them, we're looking at 57. So just shows the importance of that role, how we, can strategize of establishing that and moving forward. Now, I do have plans to incentivize PECs when we launch this readiness project. Everybody here who's been a first responder, physician, we like challenge coins and we like certificates. So I have gotten approval through some wording. It's not marketing material, but it's promotional material to support a function within our performance measures established by HRSA. So at the end of this project period, we should have not a lot of money left over, but we should have enough where I can develop, model, and create challenge coins that will be given to each PEC that's specific to Nevada with their number of the PEC that they are, as well as a certificate saying that they are certified as a PEC through the Nevada EMS for Children's program. If you give somebody, you're asking somebody to do a little extra work, but they get that recognition that what they're doing is important, I think will be very instrumental in doing that. And I do plan on doing that as well for the ED readiness as well, actually. So we're just got to see how much money we're going to have at the end of the year and what we can do to market it. But promote the positions, but it would be really good. So skills check or frequency of skills check is down to 33% at the ILS agencies. Because we require demonstration at a skill station, 92%. I got to talk to some of these agencies or John, maybe since you're in charge of education, go, why, if an EMT to a paramedic is required to do adult and pediatric skills at a skill station for their skills verification, why aren't these all 100? Except for obviously, demonstration at a skill station across the board should be 100%. Demonstration within a simulated event or observation at an actual patient encounter, obviously that's going to vary. But those are things that we can improve on. And sliding down one more time, 67% said they had disaster plans that include children. And only for the ILS agencies, only 17% tracking of children separated from patients. That's down from 50% for the ALS agencies. So it's really this discrepancy of what we see within these departments and see what is being done differently that potentially might actually make it easier for these volunteer agencies in the long run. It's going to be a lot harder to reunify a family if you don't know where the child has went. So using their triage tools appropriately, smart triage, salt triage, most of the triage tools now, if you do them correctly, will tell you, or the triage liaison or triage officer will say, this person, here's their tag. Okay, Billy went to UMC, Sarah went to Sunrise. At least some sort of tracking there. So now the BLS agency, it is within the EIC and Nevada EMS, or not Nevada, EMS for Children's Data Center, not to release agencies if there's less than 5 because they're easily identifiable. I know who our 3 BLS agencies are. I will say it is very similar to the ILS. I think that's because we're still working with the maybe 1 or 2 paid coordinators, directors, and then everybody else is volunteer, but they're very similar. So running off, effectively assuming that the BLS and ILS agencies, combining them into this report that's public is fairly appropriate. If you're dying to know a certain metric about a BLS agency, I'd be happy to give you in contact with them, and they can provide you their actual agency report that has their name and shows every answer that they've provided within the survey that they took in 2024. Dr. Jensen, I see you have your hand up.
My question was going to actually be back to when you were discussing before about the recognition, from the EMSC. One of the things we might want to do is reach out to the Nevada chapter of the AAP to see if that could be co-sponsored. In the Nevada chapter of the AAP, we don't have any money to do any of that, but I don't know if having our name on that recognition as well would be of any benefit.
I think it would.
So just some thought. If you do think that would be interested, is something you would be interested in doing, then great, let me know, and we can talk to Leanne McAllister, who is the person who helps direct that. So anyway, I know that was going back in time, but
no. Oh, my memory's not that bad, luckily. So no, I do think that would be good. Especially with potentially, I think that may have more weight with that name with the emergency department readiness project. I could be wrong. I'm misspoken. I'll be honest with you. I didn't know what the AAP was when I was a provider and a wildland firefighter and an EMT in the Bay Area, but maybe that was just my ignorance is bliss. But I would be certainly happy to potentially have some sort of certification where it's sponsored by signature by our office, whether that's me, Bobby, our administrator, whoever wants to be. I have no problems having my signature on a certificate, but if they want an upper level administrator for the Nevada Division of Public Behavioral Health, which represents our program, great. And then a signature of AAP showing the collaboration between both programs, I think that would be a good idea.
Totally your call on that. It's just if they're wanting something that, especially because the AAP is pushing also some of these, readiness, and the PEC is really kind of felt to be the key aspect.
Yes.
So go ahead, Irene.
Sorry, I need to jump off in just one moment, but I wanted to mention there are a number of gap areas that RAPM and Pediatric Pandemic Network have information on that could be helpful. So I'll make sure and supply those. But one I wanted to point out that's should be issued in the next couple of months is a reunification toolkit that has basic information on each piece of reunification and considerations for pediatrics, as well as a set of appendices with checklists and templates and other information and resources that will be useful in developing a more complete reunification plan or a reunification annex. So as soon as that is ready for prime time and published, I will make sure that you receive it, because that seems to be the most problematic area for both of these results. So I want to make sure we have that. We also have a family reception site template and guidebook for that Rapin published a few years back for the hospital setting. So I'll combine together and send them to you because those seem to be the large gap areas.
And you and Dr. Jensen hit the nail on the head. Tech coordination and having a designated position within a department and family-centered care, which is the reunification, all that. Those are the two big points, not only for our state, across the nation, that we've discussed on the NASEMSO Pediatric Emergency Care Council, et cetera. So I'm very excited to maybe have some resources. And my goal is potentially working one-on-one with these agencies as we progress through the EMS and ED readiness projects. Say, hey, this was your score. This is the resources to improve those scores. Let's work together and see how we can assist you. So, Dr. Jensen, is your hand still up? Sorry, I don't know how to not raise hands on this little tablet I have here. So if you would like to comment.
No, it's not. I was trying to get it to come down. I got distracted with some work that I'm having to do here at the same time.
No worries at all.
So just a few comments. Anybody that wants to see what the ramifications are of not having a program to keep families together should watch the documentary that's streaming on Katrina. It's a classic case of the major ramifications and the disastrous things that happened when families were separated for months.
Yeah.
Secondly, we've started now in the Southern Nevada Health District, every EMS protocol that we have, we include QI metrics. It's a very easy thing to do. So the protocol says give epi. So the QI metric is check, just make sure the right doses is given.
Yeah.
So if we do that, if we incorporate those into the protocols, then there's your QI. You just have to follow that data and then you've got your QI program.
Is that within the hospitals or the EMS
this is
agencies?
EMS.
Okay.
So every EMS protocol that comes out, there's designated QI metrics to follow in that protocol.
Yeah.
And then they just have to be followed. I think the other issue is that we're not good data collectors in this state.
No.
So when you look at what the state collects for EMS, the only thing that I can see they collect is whether or not somebody got epi, period. So we need the data that everybody has, and we need to be able to process it to make these improvements.
The data side is very rough. I've done some QA reports of things that we've heard, especially tracking down cardiac arrest as far as the Helmsley AD initiative.
Right.
I pull up the report and there's nothing there but a narrative, and they do the very bare minimum. So I have talked to Bobby and Kevin Haywood, who is not available today, our data manager for the state, of seeing how we can increase our validity score.
Right.
To get better data, but at the same time, we don't want to increase the validity score so high that we don't get anything back at all. So it's
if we use Hantebi, that data is all there.
Oh yeah, and it's
What
great.
we have to do is mine it.
Yep.
And use it.
Yep.
It'll be collected for us. So
Yep.
that's another reason to use it.
Yep.
Yep.
Especially procedures is just great.
Right.
So, does anybody have any other questions about the state summary report? And I know it was kind of a lot. If you didn't get the ALS version, please send me an email. I'll resend it to you directly. Sometimes when I do group messages through Outlook, it gets a little funky. I know right now our Outlook is still affected by the cyber attack, and I can't pull up our entire advisory committee and send everybody an email. I have to go into my contacts, find the contact group, and send an email out that way. I used to just be able to type EMS advisory committee and everybody would pop up. So might be some technical issues, but this data that we received in 2024 is going to drive the EMS pediatric readiness project that I am currently working on. So
Thank you, Cole. Emergency Department Hospital Recognition Program Implementation and Application Review.
you want to take this or you want me to?
I'll start.
Okay.
So we have all the applications. We're all ready. We actually have 2 completed applications by the highest level PEDS EDs in our state. And we were ready to roll it to all the other freestanding EDs and EDs. And then HRSA said, wait a minute, you've got to get our approval. You can't do this without our approval. And then the federal government shut down. So they're all on furlough. So until we can get approval from them for this project, we can't roll it out, which is, I don't understand because I've done this in 2 other states. We didn't have to have approval, but okay, we'll play the game. So
I talked to Alaska. They're like, what?
I know. So, but this will alleviate a lot of these issues because we require a PEC, we require QI, we'll help you set it up. It will alleviate so many of these issues.
They're required to take the survey.
Right, they're required to take the survey. And so if we can just get that up and rolling, then
Yeah.
it will really be helpful,
Yep.
but it's just frustrating that we can't.
Yep, I agree. I have nothing more to add. We're kind of in limbo with HRSA. They had some corrections. We sent them back corrections. They had clarifying questions. Dr. Horning put that together. We sent it back, and then we obviously have not heard anything back for them in about a month because of the shutdown. So, and they've been strictly told. I heard that just rumors. Take this with a grain of salt because what you hear throughout the nation varies, but I've also been told that HRSA asked for federal agencies are not allowed to communicate with grantees during the federal shutdown. So even if they're working, they couldn't talk to us anyway, which seems crazy to me, but that's what I've also heard. So hopefully any day now it'll be blasted on all of our phones and news outlets that the government is open, and then we can kind of get the ball rolling again, because our goal was to get this rolled out and the first hospitals recognized by the end of this year, and we're getting very close to that deadline. So
we already have 2 completed applications.
Yep.
All right, Emergency Medical Services Pediatric Recognition Program upgrade.
So that's me, and I apologize, everybody. Between our last meeting and then all of my data, resources, documentation being locked away on a server that we didn't have access to for going on 2 months about. I have not made progress, but I do have a great template. It's actually one of they were recognized nationally for their program, and it is Arizona. They have, it is called their MARC initiative. I wish I was creative enough and come up with these cool acronyms. We're going to have to find one for EMS eventually, but it's Making Arizona Ready for Kids. And they have a big packet with 4 levels of pediatric readiness, and I've been given permission by the Arizona EMS for Children's Program Manager to utilize that stuff. So she emailed it to me before she departed from her position. I'm reworking it, rewording it for our needs. They do have some rural areas in Nevada, Arizona, but it's nothing like Nevada. So we really need to see how we can incorporate our most rural frontier volunteer agencies, at the BLS level to make them at least meet a marker and have them have incentive to get and maintain that endorsement. So I am working on it. I hope I have something a little more concrete by next meeting, but it really depends on the ED readiness project, because once that's up and running, that's going to be our first priority, is getting multiple agencies, multiple hospitals from throughout the state signed up, ready, and reviewing applications is going to take some time for some of the people on this committee to accomplish. So it's kind of up in the air, but I would like the EMS pediatric readiness project to be rolled out and have at least a handful of agencies throughout the state by the end of 2026. And I know that seems like a long time away, but we're all going to be sitting here in August of 2026 going, I can't believe it's almost the end of the year. So it's going to come by faster than we know it. But I apologize to everybody not having anything a little more to add to this, but I should be able to provide additional information during our next meeting.
Thank you, Michael. Supraglottic airways for pediatric patients training and assessment survey.
So Mike Bolu, again, that was Dr. Slattery's role. He did send our committee a practice survey out to see if there's any kinks or issues with completing the survey. I completed actually a couple with varying levels of to we don't do much of anything to we do everything great. I didn't have any issues. I don't know if anybody else completed that survey, reported to Dr. Slattery that he had issues. Did you have?
I didn't have issues.
But I found out this morning at our lovely media event that Dr. Slattery retired and they had a retirement party last week. So I will reach out to him directly and see where he is at. That being said, his position will be open. And we actually have another departure. Stephanie Mead retired as a field paramedic, so she was unable to fill her role as well. She is still heavily involved in EMS education at Truckee Meadows Community College, but since she was not a working medic, she could not fill that position. So next meeting, we're going to need to find or eventually, we do have 19 other people on this committee right now, or I guess it would be 18 with Dr. Slattery leaving. But a physician with pediatric training. And we actually had two, we have two, but Dr. Jensen's a busy man, so I think two would be appropriate for some of the projects that we're working on. Actually, we had three because you are also one. I was looking at you going, wait a minute. So we can I guess we can kind of have a discussion. Do we think we need to add a third one?
It's up to the committee.
Yeah. I mean, if you see the benefit of having a third physician with pediatric training, by all means, I'm more than happy to have somebody. I do think maybe it would be beneficial to have somebody from Northern Nevada be involved in that as well. So we have coverage throughout the state. So maybe we can reach out to some like renowned children's hospitals, see if any of those positions are there. I think that would be highly beneficial. So maybe that's the route we go is focus on somebody from either Northern or rural Nevada to provide input as well.
That would be good.
So if
Hey, Mike, this is Seb.
Yes, Seb.
Our medical director, our assistant medical director, he works in both the pediatric and the main ER at Renown. We can discuss it with him potentially.
That'd be awesome.
Zeb, absolutely. If he wants to participate in the meetings, please let me know. Send him his contact information to me or send my contact information to him. All we really need is simple CV and a letter of interest that they are interested in participating in the meetings and they will attend quarterly and all that stuff. But I think that would be great. Okay. I appreciate you mentioning that, and hopefully it works out. And then we'll also be looking for a paramedic, but that one's a little easier for me. I'll send out a thing next week to all the EMS agencies and providers saying, if you are an active medic practicing in the field and you would like to join the EMFC committee, send me your information. You send me your resume, send me your letter of interest, and we'll go from there. And I already do have a couple of people. Stephanie recommended one provider outside of that is still working at Banner Churchill out in Fallon. So we'll see if she sends me her information and she'll be on the agenda. So maybe we'll have two positions to vote on during our next meeting. And then, like I said, I will follow up with Dr. Slattery directly and see where he's at with that. But I do see the need of supraglottic airways. I know he was a big advocate for that. And that will be, depending on what sizes it goes down to, will be a proponent of that EMS readiness project as well. Because it sounded like Clark County was going down to neonates now for iGels, which is great.
Yes. Yeah.
So every agency here is doing that all the way down to.
Yeah.
Yeah.
Trying to get them to do that. Yeah.
So I will table agenda item 9 and I'll put it back on the agenda to provide an update, depending on what Dr. Slattery says. And then maybe we pick it up elsewhere or we figure out what path we want to move forward since his retirement. So, but I wish him the best.
All right. We have proposed meeting dates for the next year, February 4th, May 6th, August 5th, and November 4th.
So I just kept, if any, please provide comments you have. I kept the same schedule. February 6th was already scheduled as part of this project period. So it's really May, August, November are the new dates. I'm sticking with the first Wednesday of every month at 1 o'clock. Because if 1 o'clock doesn't work for you, let me know. We can move it to, I know that's close to lunchtime, so if we want to move it to 1:30, 2 o'clock, that's an option. It doesn't need to be now. I could also put out a doodle survey or a survey monkey asking the committee members what time preferences they would prefer. For me, afternoons tend to be better because it's very difficult for me to get if we had a meeting at 9, it's very difficult for me to get a flight from Reno down to Vegas, get a motor pool vehicle and get to the conference room by 8:30. But I will hop on a 6 a.m. flight if it's available, if that's what we all want to do. I'm certainly willing and flexible. So if we stick with the first Wednesday, great. If you go, hey, Mike, this is really difficult, 1 o'clocks aren't great for me. We can consider that as well. The only caveat is pushing it back too far. If we do meetings at 3, we're running past 5 o'clock if it's a long meeting, and then that causes difficulties for scheduling as well. So does anybody have any suggestions about dates or times? Hearing none, then we'll stick what's on the agenda. And if you have conflicts that you don't want to bring up, just shoot me an email, call my cell phone. I'll happy to put out a poll and change the times or the days even. So great.
All
Hey,
right,
Mike.
second.
It's,
Oh, go ahead.
Yeah, Zeb, go ahead.
sorry, I thought we were gonna have a new business area, but I'm just looking for a recommendation from the committee physicians, about needle cranks in pediatrics. And the TP's resuscitator tied into those interventions, or is BVM still more recommended way to administer oxygen through those needle cranks?
Cutting out.
Yeah. Hey, Zeb, we're losing you. Can you repeat that? I'm sorry.
Yeah, so I'm looking for recommendations for needle cranks on beads, right? And it's not necessarily the crank itself, right? We already know it's not gonna deliver that much oxygen to a patient, but are BVMs still the preferred method of delivering oxygen, or are we going to start moving towards potentially using the TPs as a kind of modified jet insufflator, pressure between like 20 and 50, or what are our thoughts? Trying to figure that out because we know the needle crank with the BVM is not necessarily optimal.
So Zeb, I can send you some information about that.
Okay.
Okay.
Yeah, we can talk about it because I agree with you, but when you hook that up, it's so unstable, that way.
Yeah.
Yeah.
So yeah, we can talk about that.
And if you can send it to me so I can share it with everybody else, because maybe
Yeah.
some other agencies or other departments are
Yeah.
thinking along the same way. Is this being looked at county-wide, Zeb, or just for TM?
No, it's just for TM. We did a training with a burn infant scenario, and we had our providers do the needle cranks to them, and probably about half the catheters bent.
Yeah.
And so like not delivering great oxygen to the kids. We're looking at, there are completely off-label modifications for the TP resuscitator where you open up the PEEP all the way, increase the pressure, and use it as a makeshift jet insufflator to help with that negative pressure on the outside of the catheter. But there's nothing that supports it completely. So like we're trying to find like what is the best way that is supported for us to do it.
Well, this is very timely because there's been a lot of literature about this recently. So, yeah.
Perfect. Yeah.
Okay.
Dr. Horning's going to reach,
Right,
give it to you, Zeb, and then she's going to share it with me as well, and I'll share it to the committee. So we're all kind of up to the same page. And if either yourself or Dr. Horning feel like you want it on the agenda item, just send it over to me. I'll make sure it's on the next meeting's agenda for further discussion as well.
Okay, cool.
Thanks, Zeb.
Second public comment. Okay. Any other comments from the committee members?
Yeah, Michael Wolf for the record. Sandra, Dr. Jensen, I just want to say thank you again for being at our meeting today. That was great. We appreciate your attendance and your support for the project and initiative, and hopefully we have another event like that soon
Yes,
for something else that we're
yes.
solving and fixing, right? One problem at a time. So I just want to thank you guys for being at the event today and showing your support for our program and our initiatives, and it was very well received, so we appreciate it.
Thank you. It was fun. All right. Do I hear a motion to adjourn?
Michael Bolaloo for the record, I make a motion to adjourn.
Second?
September 2nd.
Anyone opposed? All right. Thank you guys so much.
Thank you, everyone. Have a good afternoon.
Thank you.
Thank you.
Can you give me Vanessa's?